Hello, check. What credit check? Check.
Good morning, worthy teachers. Today I'm presenting mortality meet for the Department of Hepatology for the month of June 2026. Um, Total number of hepatology OPD were 8,142. IP admissions were 932. Total procedures done in the Department of Hepatology were 1,838. Total ICU admissions were 162 and ICU deaths were 66. I'm presenting morbidity for two cases. First is Mr. Vikas Kishore, 37-year-old male. He was a case of cirrhosis cryptogenic with portal hypertension, prior bleeder. He had high-risk varices for which he underwent EVL on 16th of June 26. He was decompensated in the form of ascites, jaundice, and acute variceal bleed. He had a MELD of 25 and CTP-12C. He presented with the issues of pancytopenia. He was planned for splenic irradiation, but it was not feasible in view of ascites. So he underwent partial splenic artery embolization on 9th of June. His pre-embolization TLC was 2.8, HB was 8.6, platelets were 19,000. Post-embolization, his TLC increased to 13,000 and platelets increased to 61,000. But post that, he had SBP, he had fever, ascitic tapping was done that showed SBP. He had AKI, his creatinine increased from 0.7 to 1.6. He had sepsis-induced NCAF and he had acute variceal bleed. His TLC increased from 2.8 to 13 to then 11,000. Creatinine improved. His bilirubin worsened from a total of 3 to 4.2 and currently it is 14. AST, ALT rose from 40 and 24 to 61 and 71. On 15th of June, patient developed fever. Ascitic tapping was done, which was suggestive of SBP. On 16th, he complained of melena, for which UGI endoscopy was done, which showed grade 3 varices and DVL was done. He was shifted to HDO, bleed was controlled, AKI was corrected, SBP resolved with antibiotics, and he was shifted back to ward. And next was Mrs. Nutan Singh, 56-year-old female. She was a case of CLD autoimmune related portal hypertensive bleeder with grade 2 varices with RCS. She underwent EVL on 10th of June. She had prior decompensations in the form of ascites and HE. She currently presented to us with complaint of melena, for which she underwent EVL. She developed hemoperitoneum post-ascitic tapping. CT angio was done, which showed active extravasation from right inferior epigastric artery. Percutaneous blue embolization was done. Post that, patient was stable. Vital monitoring, HVPC monitoring was done. We are presenting one mortality case report. Patient named Mr. PC, 38-year-old male from Abdullahpur, Uttar Pradesh, farmer by occupation with no prior comorbidity. He had a complaint of fever for the initial 2 days, that is 8 days before presentation, vomiting for initial 2 days that subsided. 2 days before presentation, he had yellowish discoloration of eyes for 2 days and altered sensorium for 1 day. Initial assessment in emergency showed he was stuporous with GCS of 3/15, heart rate of 108, MAP of 83 on noradrenaline of 20 and vasopressin of 1.4. His respiratory rate was around 32. SpO2 was 90% on 10 liter of oxygen. His RBS was 124 per abdomen, soft, non-tender. Hepatomegaly was there with liver size of approximately 16 centimeter. Chest showed bilateral coarse crepes. IVC was 1612, no pericardial effusion, normal contractility. For cerebral edema assessment, ONSD right was 5.5, left was 5.6, pupils for bilateral 3 mm showing sluggish reaction to light. NCCT head could not be done. This was his X-ray on presentation. For workup, his hemoglobin was 10.3 with TLC of 22,000 and platelets of 106,000. His PT was 40 and INR of 3.56. His ammonia was 2,070. He had a total bilirubin of 5.6 with direct of 3.27 and indirect of 2.33. His AST was 35,961 and ALT of 9,683. His SAP was 826 and GGT of 526. His total protein was 5.73 with albumin of 3.02. His urea was 129 and creatinine of 5.14. Sodium was 136 and potassium was 7. His ABG on 10 liters of oxygen showed a pH of 7.16 with PO2 of 90, PF ratio of 76, PCO2 of 49, lactates of 6.4 and bicarb of 23. From his outside investigation, anti-HAV and HEV were outside negative, could not be done here. His autoimmune profile was not available. Outside, one test showed PYVX positive. Clinical diagnosis of hyperacute liver failure with jaundice to HE of 2 days with etiology indeterminate was kept with the possibility of PYVX as it was positive outside could not be repeated here. This was his course. He was received in ER at 6 p.m. from outside hospital, had shock and altered sensorium on presentation, intubated in ER for poor sensorium, antibiotics and antimalarial given in ER as outside PYVX was positive. He was shifted to LCICU at 10:30 p.m. Had metabolic acidosis, shock and oliguria with urine output of around 5 ml per hour. He was advised for LT. A referral was done attendance council, but they wanted time to decide for the same. CRRT was started at around 1 in view of metabolic acidosis, hyperkalemia, oliguria, but it was stopped in view of worsening shock at around 1:45 p.m. At 2:10, patient developed cardiac arrest. CPR was given, and patient was revived. This was his ABG post CPR. His pH was 7.13 with a PO2 of 121 and FiO2 100. PCO2 was 42, lactates of 13 and bicarb of 16. At 5:15 a.m., patient again had cardiac arrest and could not be revived. This was his post-mortem liver biopsy. It shows necrosis with few viable hepatocytes. This shows a portal tract with surrounding necrotic hepatocytes with eosinophilic degeneration. This was the post-mortem biopsy report. It showed occasional portal tracts comprising of minimal inflammation, comprising of lymphocytes and neutrophils, bile ducts seen in the tract with evidence of injury. Liver course shows coagulative necrosis with only focal groups of viable hepatocytes. These hepatocytes display eosinophilic degeneration and macrovascular steatosis. Intervening sinusoids are congested. Scattered lobular inflammation seen comprising of lymphocytes and neutrophils. Sinusoids are dilated focally. There's no increase in fibrosis. It was compatible with multi-acinar necrosis and compatible with ALF.
So back to the biopsy again. It's also full of RBCs. You can see that there are lots of RBCs. Actually, this is a total coagulation necrosis. Very few hepatocytes are less. Very few viable. There are no
These are the
nuclei seen. Yeah, only nuclei are seen.
Yes.
Very few. Okay. The pathology colleague, Chagana, Rachna, Neha, can you give more ideas on this biopsy? Because this guy had 38,000 AST. Any investigations? Some fat in the hepatocytes, but otherwise, this is an ALF.
Just sorry, I have just
Okay, go ahead. Go ahead. Sorry, it just took you off guard.
Points to discuss are causes of ALF or ALF mimics with high transaminases and AST more than ALT in systemic diseases presenting as ALF mimic with AKI. First is autoimmune hepatitis, which usually has ALT more than AST, but AST more than ALT may occur in advanced cirrhosis or severe flare. AST level are moderate to markedly increased. Bilirubin may increase in severe AIH flare. Alpha GGT can be normal to increase. Typically, there are marked transaminases with relatively low ALP and high IgG. In acute ischemic hepatitis or shock, AST is more than ALT with massive increase in AST levels. Bilirubin mild, initially it is mildly increased. In acute muscle injury and rhabdomyolysis, AST is more than ALT and AST levels are typically markedly increased. Bilirubin is typically normal and there are normal GGT and ALP levels. Additionally, CK levels will be markedly increased and isolated AST predominance with normal liver-specific markers will be there. In Wilson's disease, acute liver failure, AST is more than ALT. Often it can be more than, a ratio can be more than 2.2. AST is moderately increased. Bilirubin will be high. ALP will be disproportionately low. In drug-induced liver injury, mitochondrial toxicity, AST can be more than ALT with moderate to severe rise in AST. Bilirubin levels can be variable. In acute liver failure, in late stages, AST can be more than ALT, but there will be falling AST, ALT levels despite worsening of disease, and bilirubin will keep on rising. Rickettsial disease can have AST more than ALT along with thrombocytopenia and hyponatremia. AKI can or cannot be there. In the liver manifestation, there can be mild hepatitis to liver dysfunction with AST more than ALT, mildly elevated SAP GGT. Bilirubin can be normal or mildly increased. INR can increase in severe diseases. In the renal manifestation, patient can have AKI due to vasculitis, hypoperfusion, and ATN. There will be increased urea creatinine. Hyponatremia is commonly seen. Patient can have proteinuria or hematuria along with hyperkalemia and severe AKI. In Leptospira, classic Weil's disease shows jaundice, AKI along with hemorrhagic manifestation. In liver, classically cholestatic hepatitis is seen. Marked jaundice disproportionate to transaminases will be seen. Bilirubin will be high. AST, ALT mild to moderately increased. SAP, GGT can be mildly increased, but synthetic function are usually preserved. In kidney involvement, AKI can be due to tubulointerstitial nephritis and
Doctor,
ATN.
I would like to know where are you really, what is your exact working diagnosis? This liver was not cholestatic, was it? So why are we going here? We should know those 4 or 5 causes that you had thought of.
Ma'am, actually, we could not work up the patient completely. Secondly, his transaminases were very high. So, and creatinine was 5.14. We don't have the
A good clue, and that is the biopsy of the patient.
yes.
That would have helped you in making a difference, at least a broad difference.
In severe dengue, patient can have fever with thrombocytopenia along with AST more than ALT and hemoconcentration. AKI may or may not be there. In liver involvement, hepatitis can be due to direct viral injury and immune-mediated damage. AST more than ALT is characteristically seen with mild to moderate transaminitis. In AKI, in kidney involvement, AKI can be due to shock, capillary leak, or abdomyolysis. Urea creatinine are raised with proteinuria being common. Hematuria may occur. In severe malaria, patient can have cerebral malaria along with AKI, jaundice, and severe anemia. In liver involvement, mild to moderate hepatocellular injury is there. ALF is rare. Jaundice is due to mixed hepatocellular injury and hemolysis. Bilirubin is markedly raised. AST, ALT are mild to moderately elevated. SAP, GGT can be normal or mildly increased. In kidney involvement can occur in severe falciparum malaria due to ATN or acute interstitial injury. With raised urea creatinine, patient can have hemoglobin urea and electrolyte abnormalities like hyperkalemia, metabolic acidosis, and severe AKI may require dialysis. Even heat stroke can have involvement of liver and kidney due to ischemic hepatitis and direct thermal injury. AKI can be due to hyperperfusion, rhabdomyolysis, and ATN with increased urea creatinine, myoglobin urea, hyperkalemia, and metabolic acidosis may be there. They can be marked AST and ALT elevation with AST being more
Doctor,
than-
this particular effort is meant for you and for us to come closer to the diagnosis, not just open the whole plethora. This is just you just telling us and we are listening to it. But we'll have to, your first slide when you started the causes is probably where you should go back and think about the cause. Carry on like this, so heat strokes se leke everything is there, and you've not decided the diagnosis.
Incidence of AKI in ALF.
What Dr. Seema is saying, do we have since the patient was there only for few hours? So we don't know. What you are describing is very high AST, specific systemic diseases causing ALF maybe. Is that what you say?
Yes.
But the outside, Satyendra, what do you say? Seema has a question.
So they might not be a single cause. There might be a systemic disease, and superlated with the ischemic hepatitis patient was presented with a norm of 20. So the very high AST 35,000 can be because of the ischemic hepatitis, which superlated with the preceding P5X, which was already positive. And we have seen the case reports also that it can cause. But patient stayed with us for a few hours only. We could not confirm, we could not send P5X or P-falciparum, which is predominantly the cause for the severe malaria inside, because he stayed in the night only. He came in the night and expired in the night. So there might be two causes.
The idea of presentation is to get everyone's opinion. What could be the cause in this case? It says we could make a diagnosis except biopsy postmortem says only. We don't know the cause.
This shows the frequency of AKI in ALF. In a study conducted by Acharya et al., AKI was seen in 13% of ALF patients. Another study shows incidence of AKI to be 30% and 30% in ALF patient. In a study by Bhatia in hepatology, AKI was seen in 9% of total patients. Comparing the lab parameters between ALF and ALF mimics, significant p-value was seen for hemoglobin platelets, uh, hemoglobin and thrombocytopenia, which was seen more in ALF mimics compared to ALF. Bilirubin more than 10 times of upper limit of normal was seen more in ALFs, and ALT more than 10 times of upper limit of normal was statistically more in ALF compared to ALF mimics. LDH more than ALT was seen in ALF mimics compared to ALFs. Etiology in ALF mimics. This study shows that malaria was the predominant cause of ALF mimics, seen in 58% of ALF mimics. Causes of cardiac arrest in ALF, as this patient had cardiac arrest twice during the stay. He had one of the causes is electrolyte derangements with severe liver dysfunction disrupts the body's ability to maintain homeostasis. Profound hypokalemia, hypophosphatemia, and hyperkalemia directly may induce fatal cardiac arrhythmias. Severe lactic acidosis, as the liver fails, metabolic clearance drops, systemic perfusion decreases, leading to severe lactic acid accumulation, which weakens the cardiac contractility and triggers arrhythmia. Cerebral edema and vein herniation due to elevated ammonia levels can lead to astrocyte swelling and catastrophic intracranial pressure. If left unmanaged, vein herniation occurs, leading to respiratory arrest followed by terminal cardiac arrest. Myocarditis can be seen in few systemic diseases which affect liver and heart both, like scrub typhus, hepatitis E, and HSV.
What could we have done better in the 10:30 to 5:30 time?
Yes, yes, ma'am. Outside creat was also 3.79 and ours was 5. Yes, ma'am. Potassium. Yes, ma'am. Potassium was also 6. Yes. Ma'am, at 1. Ma'am, around 6 hours after ER presentation and
That,
2 hours after admission.
that is the most important.
Potassium was 7,
So,
not 6, and that was in my mind one of the things. The patient reached ICU at 10:30, Satinder, and we started CRRT at 1. So I think from emergency to ICU, we should improve, no doubt. Nevertheless, we couldn't understand 38,000 AST in him. So I requested to present this case for learning. Yeah, ischemia, and that could be the cause for renal injury also.
One message is like ALF patients should be immediately shifted to the ICU.
Yes,
That we should all agree, and we should make a different plan for these patients.
it's
The best course for that would be let them get shifted without getting the formalities of depositing money and all that stuff, which we were doing earlier.
not by
We
review by
We take an
CC.
undertaking from them that they will deposit the money, they should be immediately transferred. It takes a couple of hours for that. Sometimes people to arrange finance and all that. So instead of that, if we can do that for ALFs, that they get into ICU with an undertaking, that they deposit the
And we
money.
should be a complete
And also,
team person.
they are accompanied by team.
You have a second case?
yes.
Thank you, Meenakshi. Be very quick because we have 3 presentations. I don't know if we have time, but make like this. Yeah, they missed last time. We should not. Madam. Okay, Vinay, you are lucky to escape. All right. HPV.
Good morning, respected faculties and my dear colleagues. I'll be presenting the morbidity and mortality meet for this month from the Department of HVB and Liver Transplantation. So this month of June, we had a total transplants of 12, in which all were live donor liver transplantation, 6 were adults and 6 pediatric patients we had. From January to June of this year, total of live donor liver transplantation we had done were 81 and DDLTs of 5. With each month, the mortality, total mortality accounts to be 9. With June, no mortality in June. Elective surgeries, total of 58 surgeries were done. 38 were cholecystectomies. Extended cholecystectomy were 1. Hepatectomy, we had a total of 6 hepatectomies, in which 2 were hepatectomy with vascular resection and reconstruction. In one of them, we did a segment 4 artery with the common hepatic artery reconstruction, and in the second case, we did a right hepatic artery and right portal vein reconstruction. We had 2 hepaticojejunostomy cases, 3 pancreaticoduodenectomy, out of which one was Whipple's with a vascular reconstruction and resection and reconstruction. We had single case of novo donor hepatectomy. The patient actually had an intraoperative diffuse tubercles in the peritoneum. So with an diagnosis of active TB, we had deferred the LT. We had a case of median pancreatectomy, a case of diagnostic lab with biopsy of an omental nodule, case of HCC with an omental nodule biopsy was done. As case of cystopericystectomy, case of Kasai portoenterostomy, single case of cystogastrostomy, and a case of diagnostic laparoscopy with a laparotomy trial dissection of a gastric cyst. This was a malignant, very large malignant cyst with a pancreatic involvement. In emergency cases, we had a total of 8 cases, 2 cases of exploratory laparotomy, 1 case of redo hepatic artery anastomosis, 2 Bogota closures, 2 umbilical hernia repairs, and a secondary abdominal wall closure. For morbidity, first cases of baby, 1-year-old baby A, case of CLD with biliary atresia, status post Kasai. He had undergone left lateral lobe LDLT on 2nd of this month. He had surgical site infection with wound dehiscence and burst abdomen on post-operative day 8, underwent the Bogota placement on POD 8, Bogota exchange on POD 13, and last secondary abdominal closure on POD 20. Now the baby is doing fine, and he's taking orally and passing stools. Second is a case of 1-year-old baby R, case of CLD biliary atresia, unoperated case, underwent left lateral lobe LDLT on 19th of this month. He had a hepatic artery thrombosis on POD 1 and was taken for a exploratory laparotomy with a redo hepatic artery anastomosis on POD 2. Baby is also doing fine. His graft is working. His enzymes are decreasing and working better. Cases of mortality, we had 2 mortalities in this month. First is a case of 75-year-old lady, Mrs. BD. Case of carcinoma gallbladder type 3 block with a hilar separation. She had underwent bilateral PTBD with multiple PTBD exchanges. Was admitted for PTBD exchange on 13th. She underwent it on 13th, but she succumbed on 20th of this month due to multi-organ dysfunction, and she was in sepsis with septic shock. She had a very poor performance status, and it was a locally advanced tumor. Second is case of
Are you going to discuss this case?
Sir, both of our cases were non-surgical mortalities. So
Not surgical, but why was the patient taken up? The 75-year female. He has type 3 block. What were we trying to achieve in her?
she had come with a high bilirubin level and PTBD block. So we admitted the patient for a PTBD exchange. She underwent the PTBD exchange after admission. She was fine on first day. Second day, she started having fever and then altered.
PTBD from outside.
No, multiple PTBD exchanges were done here. Last was done on 7th of last month.
See something because such an advanced age and done this. I'm not very sure we should have intervened. And anyway.
Second case is also a non-surgical case. Cases of an acute necrotizing pancreatitis with WAND. Patient was admitted for evaluation. He was having a higher bilirubin level and he had a pancreatic pseudocyst. But after admission on 19th of this month, he had a torrential bleed and within 4 hours he succumbed. Immediate cause was cardiac arrest and mostly due to a ruptured pseudoaneurysm.
The CT angio done or no?
During our first admission, we had done a CT angio. There was no pseudoaneurysm detected. It was just a pseudocyst. And he was improving. LFTs were improving. He was his all parameters were better. Vitally, he was stable. He was taking already well. But then suddenly,
From surgery side, this is hemosarcomas.
What was the day of pancreatitis? No, that's very important.
his 22nd of April. Acute epigastric pain started on 22nd of April.
You should have told us the details because if it's an infective necrotic pseudocyst with a pseudoaneurysm secondary to that,
Ma'am, there was no pseudoaneurysm detected earlier. He was never having any history of maligna or upper GI
why
bleed.
if the patient was not sick, then why did the patient get such a bleed? So what was the background history is very important in this particular case.
He had
Patients don't die like this, pancreatitis. If they get better, they get better. They don't die.
Patient was around 8 weeks plus of pancreatitis. He presented to our OPD 2 weeks prior to this episode.
Presenting this case or no? You have the history and everything. Are you presenting?
so history is acute. He had an
Why
epigastric.
don't you present first the case?
Mrs. KS, a 70-year-old male. He was admitted on 16th of this month and expired on 19th. He had no comorbidities. He had ethanol addiction. Last intake was 2 months back. He never underwent any surgery. History, he had acute onset epigastric pain radiating to back, which was diagnosed as ANP at an outside hospital. Date of pain was 22nd of April. Since then he had multiple admission for the same and was every time treated conservatively. He was planned for ERCP and versus laparoscopic drainage procedure in view of the deranged LFT, but that was deferred by the patient. Then on 14th, he had come to ILBS OPD with weakness and anorexia. On admission, he had a single episode of fever, but there was no history of maligna or hematemesis. His investigations, he had from the outside labs, we detected that there is a decrease in fall in HB, but during the course he was having a stable HB. CRPs levels were also elevated, but that was also in a decreasing trend. He had a outside report with a 6.5 bilirubin, but after admission, his bilirubin was also decreasing. His enzyme levels were normal. After admission, we got a CT angio done for the patient, which detected acute necrotizing. There was a necrotic acute necrotizing collection with normal abnormal angiography. There was no pseudoaneurysm detected, and he also had bilateral minimal basal pleural effusion. The diagnosis was acute necrotizing pancreatitis, etiology mostly biliary or ethanol related. After admission, we started him on IV antibiotics, analgesics, and supportive measures. On 16th, he got the CT angio done, which was normal in terms of pseudoaneurysm, but he had an ANC. On 18th, since 16th, he started improving symptomatically. LFTs also started improving. He started taking orally well. But on 19th at night around 1 o'clock, he had a episode of severe upper GI bleed along with maligna. He had a fall in BP. He was having an HB of 5.2. And we resuscitated him with IV fluid, started him on NORAD, and we shifted him immediately to surgical ICU. Blood products, crystalloids, and albumin were transfused. We planned for a repeat CT.
Time frame, what time to bleed, what did you do?
He bled at around 110.
Yeah.
110 around, he started bleeding. By 1:30, he was in 1:30 he was in surgical ICU. He received blood by 1:40 and blood transfusion immediately. Inotropic support was started immediately at 1:10. Blood products was transfused by 1:40 and we got hold of, we talked with the IR team when we were planning for a CT angio and embolization, but his vitals he started collapsing, and by morning 9:30 he was declared. Since 8:20, he underwent cardiac arrest and CPR was started. He was declared by 9.
You were CT angio and embolize.
No, we couldn't get a chance for shifting the patient for CT angio. He was on inotropic support and he was collapsing.
Doesn't excuse. You have somebody from IR.
So we had
Nobody.
actually discussed even for getting a direct DSA done because he was bleeding torrentially and we knew that shifting to CT would take time. We patients BP was not going up beyond a map of 40, 70, 50, 70, 40 was his BP. Despite continuous transfusion of products and crystalloids and colloids, but they wanted a roadmap because there is a previous CT angio which is negative, which is done less than 48 hours back, and they felt that this would lead to multiple negative embolizations and not benefit the patient. So actually the history is that he
What
gave,
is the lesson? How can we improve? You know, we lost a patient.
and this is so sad because when he came without any history of bleed, we got a CT angio done preemptively on him, and we had discussed that, and there was no evidence and there's no history for bleed. The reason he was admitted was because he was having a poor appetite. He did not have any fever. He did not have any pain. He was just admitted for poor appetite. Other parameters, he was on our OPD follow-up for 3 times. He had come and his
No, that's
initial,
all right.
so he was improving at that point in time. His CRP was going down. His TNC was normal.
I'm not doubting what I'm saying, Ragini. I share your loss and feel that you are also very depressed in that. But the question is, what could we have done better? We should have straight away gone for DSA and overrated
Yes.
the IRP.
That was the only thing that I could think of, that let's not waste time with CT. Let's take him directly to a DSA, and we did discuss that with the IR team, but they were not.
Nobody from IR. Amar or Vishwant, it's not clear. Okay. We lost him because of in-hospital bleed which could not be detected and controlled.
Ragini, any role of exploratory laboratory, laparoscopy, guided vessel migration?
The point is that we have absolutely no clue where he's bleeding from. So even if we did open him up, I don't think we would. I mean, at least if you know it's localizing, it you know it's from the splenic artery sides, from the GDA sides, from the left gastric side, there's some role of packing to stabilize. But when we don't know where it's bleeding from and it is basically fistulized luminally, we will not be
He
able
had
to pack.
hemoperitoneum or
No
was
hemoperitoneum.
it bleeding in the gut?
He was bleeding only.
He was intraluminal.
only intraluminal.
So it is hemosuccus, one of, as Rakhi says, one of the approaches could be exploration. If nothing is there, one could have tried. Okay. Have you reviewed? No, you shouldn't review causes of such sudden massive flights taking leave. What could be done? We need to know the steps so that we all are educated. That is declared, but doesn't mean what have we learned? Should have
I
reviewed.
told her to wake up few slides on how to manage pseudo aneurysm.
It's an absolute must. And we'll keep 3 minutes for you next time. Okay? All right.
Good morning, everyone. I'm here to present the data from the Department of Pediatric Hepatology. These are the OPD and IPD data, the total number of patients from February to May that came to OPD and the number of admissions in pediatric hepatology. These were the procedures done under pediatric hepatology from February to May. We had 4 mortalities, out of which one was Master S, who was a 5-year-old male who came to us for the first time in ER. He was a known case of cholesterol synthetic defect, and he came in a decompensated state in the form of ascites and hepatic encephalopathy with a bleed. He succumbed to pulmonary hemorrhage and catecholamine shock, refractory shock. Miss P, who was a 7-year-old female, who was a case of acute liver failure with hepatic encephalopathy grade 4, with a peak INR of 8.4, with pneumonia, with septic shock. Her etiology was hepatitis A, and she succumbed to multi-organ dysfunction syndrome. Master Y, who was a 9-month-old male, who was a case of unoperated biliary atlasia. He was decompensated in the form of ascites with portal hypertension. He came to us with severe pneumonia with bilateral pleural effusion with respiratory failure, and he succumbed to acute respiratory distress syndrome. And Master A, who was a 13-year-old male, who came to us with acute liver failure with grade 3 hepatic encephalopathy with peak INR of 4.3, etiology being hepatitis A with acute kidney injury and a comorbidity of G6PD deficiency. And he succumbed to MODS and rhabdomyolysis. So we will be discussing Master A, who was a 13-year-old male who came to us on 29th of May 2026 with history of prodrome from 4 days, rising jaundice and altered sensorium since 1 day. On admission, he had altered sensorium. He was combative in HE3 and his pupils were bilateral, dilated with sluggish reaction and high ONST. He had 2 centimeter liver palpable, which was soft, which indicated acute hepatitis. Initial investigation showed low hemoglobin, high TLC count, high total bilirubin with equal direct and indirect component, high creatinine of 2.25 with anuria, high INR of 4.3, hyperammonemia, hyperlacticemia, 4.1 PCT, and his etiology was found out to be anti-HAV-IgM reactive, and he had a background of G6PD deficiency with a reticulocyte count of 6%. So we diagnosed him as acute liver failure with hepatic encephalopathy grade 3 with AKI stage 3 with a comorbidity of G6PD deficiency. So on day 1, he was intubated in ER with neuroprotection, anti-ammonia measures, sedation, analgesia was started. KCH criteria was 2/5 and PSAB criteria was 2/3. So LT referral was sent. For anuria, high creatinine and hyperlactatemia and hyperammonemia, he was started on CRRT on day 1. Within 6 hours, as per Institute's protocol, high volume TPE was started because of INR of 4.3, after which the INR settled down to 1.25 at 36 hours. He had multiple ICP spikes, so propofol dose was increased up to 4 mg per kg and thiopentone was added. He had a high total bilirubin of 32 with equal direct and indirect component, indicating ongoing hemolysis, and he required multiple PRBC transfusions. So for this hemolysis, we again did a high volume TP on day 3. On day 4, he was observed to have high lactate despite improvement in liver INR. So from 8 to 80, and severe metabolic acidosis and rhabdomyolysis as his CPK was 4200 and triglyceride was 460. So we suspected propofol infusion syndrome and propofol was stopped. He also had anuria and fluid overload despite improvement in urea creatinine. His X-ray became worse and he developed arrhythmia on day 5 with having left bundle branch block with prolonged Q3 syndrome. He developed cardiogenic shock on day 5 and succumbed to multi-organ dysfunction and death. So his cause of death was attributed to HIV-related ALF with multi-organ dysfunction complicated by persistent hemolysis with rhabdomyolysis with anuric AKI stage 3 with severe metabolic acidosis and arrhythmia. His issue was rhabdomyolysis, which can be due to propofol infusion syndrome, which has an incidence of 1.1 to 2.9%, or it could be HIV-related, which is exceedingly rare. So we will be discussing about propofol infusion syndrome, which complicated our patient. So propofol infusion syndrome is a mitochondrial cascade triggered by propofol's effect on fatty acid metabolism. Propofol inhibits coenzyme Q and cytochrome C in the electron transport chain, which leads to impaired beta oxidation of fat. So fatty acids accumulate inside mitochondria and ATP production collapses, leading to cellular hypoxia, which leads to multiple organ failures, metabolic acidosis, cardiac dysfunction, rhabdomyolysis, renal failure, and death if unrecognized. So a high index of clinical suspicion is the only reliable diagnostic tool. There are no specific tests or diagnosis, so it remains purely clinical. Updated definition in 2019 stated that high dose of more than 5 mg per kg per hour or longer duration of more than 48 hours plus 1 or more of metabolic acidosis, rhabdomyolysis, ECG changes, AKI, hyperkalemia, lipidemia, fever, and raised lactate may point to propofol infusion syndrome. Our child had high dose of propofol infusion with longer duration with metabolic acidosis, rhabdomyolysis, ECG changes, AKI, lipidemia, and hyperlipidemia.
What dose was given?
Sir, more than 4 mg per kg per hour. We had reached.
Just ask you before we go to the propofol as a diagnosis, what all things were done for managing the difficult cerebral edema, refractoriness, before we go to the infusion of high dose propofol?
Ma'am, thiopental we had given.
No, that is not the way to manage.
Talking of neuropsych. Ma'am, we intubated the patient and
Because that never came out. What dose of CRRT, what was the ammonia, how was the things adjusted before we go to maintaining high propofol for managing cerebral edema? That I couldn't understand. That's what,
ONST decrease.
which we need dikhaya.
What was the effect of plasma exchange at ONST and ammonia? I must have missed it.
Sir, INR improved.
Not INR.
We don't need INR for cerebral edema.
Ammonia also improved.
We need surrogates of cerebral edema. Because that was given, because that was the challenge and you gave propofol and you yourself are putting that as a diagnosis. So I'm asking.
There must be ONSD available for with us. And there were multiple ICP spikes. We have not concentrated on that, and that's why she's not brought it out. But that was the reason why we all, with all protection, additionally, propofol dose actually.
Every child will get the same.
Yes, the protocol.
Propofol will not be, we can ask the anesthetist colleague.
Yeah.
Because every child, the VLA for others are getting the same dose.
Yeah.
So everyone should have propofol infusion syndrome.
It's not there in all patients. Like I told you, the incidence is just about 1 to 3%. And I think the anesthesia colleagues will also. So it is, we haven't seen a propofol infusion syndrome in 16 years in this institute, with propofol being used for all our ALF patients.
Maybe we never suspected.
Even we didn't. But we were, in fact, I think if I'm not mistaken, it was the anesthesia colleagues who said you should think of propofol infusion syndrome, and that's why we stopped. So that is the only one reason we can find here for rhabdomyolysis.
But what is the routine dose of upper limit of dose which is recommended? Because this is a high dose propofol. What is it?
So the dose that is meant for ICP can be up to 6 milligram actually for propofol.
I'm asking over here because you had CRRT. What was ammonia? Those things should come.
CRT actually washes away the drug. So we were giving according to the range that we are using up till now in most of our patients.
Why did CRRT fail and we had to go to this strategy? That is what I'm
No,
asking.
CRT is not the only thing that we do for ICP. For ICP, we do the complete protocol of a neuroprotection as well as for ICP.
What was the peak CRRT dose in this case?
Ma'am, 30 ml per kg.
What was the ammonia clearance with CRRT? Can show us all that.
What was the ammonia clearance?
Ma'am,
Do you remember offhand?
140 was the minimum.
From 661 to 140. She's not dying.
Yes, sir. We. Yes, sir.
It's rhabdomyolysis and
I would like to make several comments on this issue. I have been expressing my concern about the rampant use of propofol in this liver ICU. And many of the deaths which are labeled as septicemic deaths could actually be the regarding this child, the use of 4 milligrams per kilogram is a very high dose. It would, knock off the patient. It would be a complete general anesthesia. This would come down to almost 20 or 30. In this child, what was the base when you increase the propofol? Because in the presence of a BIS of 0 or 5 or 10, there is hardly any role of propofol because the cerebral metabolic rate is already down with the BIS of about 0 to 10.
but this
And there is no further benefit of using propofol in such situation. I have written an editorial on this very aspect, which is published in Brazilian journal this year, and I am questioning the use of propofol when the BIS is less than 20 or 10 and at times 0. because it has no role in improving the cerebral, further reduction in cerebral metabolic rate, no role in improving the, decreasing this ICP, and in fact, the other mechanism of reducing the, also the autoregulation is impaired. So the blood flow is also not what we think that cerebral vasoconstriction would lead to reduction in blood flow is also disproven, is not proven, because the cerebral metabolic rate or autoregulation is impaired in these patients. So 4 milligrams per kilo is a very high dose, and I don't think that there was any role in increasing the propofol dose at this stage in this child without knowing the BIS.
So now that you say, I mean, with this propofol infusion syndrome, looking back, we will think about it. But the allowed dose patients where you have ICP spikes and refractory ICP, which this patient for some time was, it's up to 6 milligram per kg per day.
This is very questionable. There is no evidence to say that this increase in dose is
Available. So this dose is available. We can show you this
available,
dose,
but
yeah.
there is no role in patient. That's what I'm trying to say.
Now, this, as far as this is concerned, I agree with you. It would be a very ideal situation if we had somebody from CCM here presenting along with us. So because they would know, they would have the data of this kind if they were keeping it all. Largely, we are doing it ourselves. So I don't know if this has been taken for this or anybody is doing that for us.
In this case, definitely is Gaurav also there, otherwise Dr. MP can inform the critical care to keep a base in this.
Gaurav is not there in the LCICU too for us to.
I suggest we must monitor BIS in all ALFs, and the dose of propofol should be titrated to the BIS and should not be blindly increased or decreased depending upon the ONSD or the spikes in ICP. No, they're not with propofol. Now, the person who is encephalopathy grade 4, what else do you want? You want to knock him off? By what? Unless there are seizures, the indication for propofol is only if the patient is moving
No, sir,
or is not tolerating the endotracheal tube or any such things.
cerebral edema, and so there is a role of propofol in refractory ICP.
Madam, there is no evidence for that. I question that, and like that's exactly what I have done in my editorial. If you are interested, I'll circulate it to you.
Sir,
Please repeat.
That will be informative. Yeah, please do that.
All right, please continue quickly. It's a very good learning for us. Yeah, we can do that.
We will have to create a facility. We have the BIS monitors, standalone BIS monitors. So we can buy those for the benefit of such patients. For all ALF, encephalopathy, you should use this.
We already ordered, sir, for our ICU. Actually, there were 3 and 1 was for the liver ICU, but somehow it was not there. So we had 3 BIS monitors and 1 was dedicated for liver ICU.
So
It is very simple when you just attach electrodes and it gives you the reading. It's
It
just
should be
give the
available,
number.
and also, yeah, I agree with it.
So the risk factors for propofol infusion syndrome are heavy or prolonged propofol doses, acute kidney injury, younger age group, critical illness, excessive lipids, dearth of carbohydrates, inborn error of metabolism, elevated glucocorticoids or steroid therapy, out of which these 5 risk factors are present in our child. So there is not much data on propofol infusion syndrome in children. However, Scott Hemphill et al. Had stated that median duration of propofol infusion could be up to 66 hours, and it can present within 1 hour also. And cumulative propofol dosage of more than 25 to 40 milligram per kg had a high unadjusted mortality risk. This carries a substantial mortality of up to 52% in children. So prevention strategies include respecting dose limits less than equal to 4 milligram per kg per hour in children and avoidance of more than 48 hours at high rates. Multimodal selection, that is combining with opioids and other agents and using lowest effective propofol rate. Monitoring proactively, carbohydrate support, avoiding high-risk use in children with mitochondrial diseases or inborn error of metabolism with escalating vasopressor use, and no prolonged pediatric ICU use. So there is no antidote. Early recognition and supportive care are the key. We should stop propofol immediately and switch the sedation to alternate like midazolam dexmedetomidine and treat life-threatening features like ECG changes, hyperkalemia acidosis, and hypotension. Early hemofiltration is required to eliminate water-soluble metabolites and supportive care in the form of dextrose infusion and ECMO in refractory cardiogenic shock. So what could we have done differently? High index of suspicion, we stopped propofol on day 4 when it was already quite late. No antidote, so stopping the drug is the only cure. No prolonged use of more than 48 hours and switching over to a different sedative in case cumulative dose reaches more than 240 mg per kg. Thank you.
You didn't mention use of 3% of menthol in refractory cerebral edema. This patient may have propofol syndrome, but other causes of managing or approaches to management of refractory cerebral edema should have been considered. And what we could have done better is mannitol is useful when you have grade 1, grade 2 HE, not once a person. Earlier the better. We should have. What was the sodium in this patient?
So sodium was 134.
So if you have 134 sodium, this is actually hugely vasodilated system. You need to give 3% or even higher.
So we had started with the
You have to
neuroprotection.
achieve 140, otherwise it is pointless.
So CRRT was only.
Yeah, but still. I'm not saying 145 or 140. 134 is certainly low. And before even you start CRRT, even in emergency, you should have started mannitol or 3%. These are very basic. But इसका sodium आया ही नहीं ऊपर. There's no mention of sodium at all in the whole management.
Actually, we can't say that we are not able to reach. Now the guidelines of CRRT is done. You don't need to put infusions of 3%. You have to adjust it with CRRT. That is how the CRRT is done for all these electrolytes and everything.
But if you are trying to increase,
No. Please
what
show
will
us
you
the
do?
data.
No,
Yes,
if you are,
ma'am.
no, if you are increasing.
No, there is no evidence.
जवाब
नहीं है।
दो, अगर
नहीं है
sodium
ना, मैम।
Anybody from nephrology?
you tell us sodium अगर बढ़ाना है तो what level?
CRRT can do.
What flow? What flow? Tell me the flow.
No. Dialysis.
Dr. Mathur, can you increase sodium by CRRT?
CRRT is preferable, sir, in cerebral edema because it cardiovascular and cerebrovascular changes do not occur rapidly. The gradual changes.
Okay.
What flow should we do to increase? I mean, this is a problem that we are facing in all our areas. Vikrant, what is your feeling? Say, tell sir.
Mannitol and various combinations. 3% I think almost all our patients are receiving. Regarding achieving the levels of 145 or 150, a substantial proportion achieve, a significant proportion do not achieve. Through CRRT, we ask the nephro team to add in the bag, which is done, but still in some patients we are not able to achieve. So that is the protocol. This part has been shown. What is done after that? That's why she has skipped the part management of cerebral edema prior to this propofol part. Propofol part after intubation, that part has only been shown in this.
This time pediatrics had enough time for discussion. You got half an hour. Okay, thank you all and be ready for the convocation. All right.